I would like to thank everyone for joining us today. This is a joint neurology and psychiatry grand rounds. When we were planning to do this back in early March, which feels like a lifetime ago now, we were worried about not having enough space for everyone in the room, but given the circumstances, I think this turned out to be a good venue, a perfect venue for this grand rounds. I'd like to thank Dr. Khan for coordinating this with us. As you know, Dr. Khan is a assistant professor of psychiatry and the director for the Center for Mindfulness Science. He will be introducing our speaker today, Dr. J. Sanguinetti. Welcome, thank you so much, and I'll hand it over to Dr. Khan.
Great, thank you. So welcome everybody. Thank you very much for joining in. And thank you also for co-hosting with us to Dr. Chu and Dr. Shalini, the whole Department of Neurology. It's really a pleasure to be able to coordinate a talk of this nature about mindfulness and neuroscience with a clinical focus in coordination with the Department of Neurology. Just as an aside, for those who are especially interested in this topic of neuromodulation and mindfulness and the philosophical kind of difficulties for some people in accepting this notion, as well as the developments of the neuroscientific investigation of its relevance for mindfulness and contemplative practice, Dr. Sanguinetti will join us again in a couple of weeks for a Center for Mindfulness Science focus talk with a little less of a clinical focus and more of a theoretical focus on mindfulness and neurostimulation. So for those who want to hear about that, you can join the Center for Mindfulness Science listserv at our website and you'll hear about that. For today, Dr. Sanguinetti, I want to introduce, is an adjunct professor at the University of Arizona and a research assistant professor at the University of New Mexico. I think that's actually old news. He's now purely assistant, he's a assistant professor at University of Arizona with the adjunct at University of New Mexico. You can correct me if I'm wrong on that, Dr. Sanguinetti, but I think I have old academic ties on this intro that I'm reading. But Dr. Sanguinetti's training was in philosophy, neuroscience, and cognitive psychology. Dissertation investigated neural processes of conscious and unconscious visual perception. He now specializes in psychophysiological measures, EEG, Fmri, and eye tracking of visual perception, emotion, and mindfulness meditation. His team is investigating novel forms of brain stimulation, including the use of ultrasound and light-based stimulation to enhance memory, perception, and well-being. He's published widely from topics on the neural basis of vision and the temporal dynamics of perception to understanding how the brain changes in Parkinson's disease and schizophrenia. Current interests include using non-invasive brain stimulation to enhance cognition, well-being, and mindfulness, and the relation between those. Jay is presently investigating whether focused ultrasound neuromodulation can augment mindfulness practice in collaboration with Shinzen Young, a well-respected mindfulness meditation teacher who is actually on this Zoom call with us today. Thank you for joining us, Shinzen. They recently launched the Sonication Enhanced Mindful Awareness Lab at the University of Arizona in collaboration with the University of Arizona Center for Consciousness Studies. And this lab is developing accelerated mindfulness protocols for therapeutic interventions to treat addiction, chronic pain, and depression. Dr. Sanguinetti is also assistant director for the Center for Consciousness Studies, which runs the largest international conference on consciousness studies. So with that, thank you very much for being with us today, Jay, and I'll let you take it from here.
All right, thank you so much for that introduction, Rael, and thanks to the organizers for organizing this. I'm sad I can't be there in person with you, but it's still quite nice to see so many people on the call. I feel like I'm getting some of my much needed human interaction by seeing all of your faces there. So thanks to everybody for joining. And Rael, you had it right the first time. I'm an adjunct at the University of Arizona and research assistant professor at UNM. So still those two positions. Although when you introduced me, you made me sound like I've been a lot busier than I feel like I've been over the last 2 months. But yes, I also co-run the Center for Consciousness Studies in Tucson. So yeah, thank you very much. Okay, so I'm going to share my screen here and let me know if you can see it. Yeah, okay, I'm guessing you can. Yes, okay. So today, I'm really happy to talk to you about our current research at the University of Arizona, where we're really interested in using ultrasound neuromodulation as an enhancement tool, both for well-being, so we're talking about clinical interventions for things like depression, as well as accelerating mindfulness practice. And really, we're interested in mindfulness first as an intervention for clinical practice as well, for things like chronic pain and addiction. So most of the work I'm going to talk about today is in my lab that I co-run with Shenzhen Yang, which is at the Center for Consciousness Studies at the University of Arizona, but also I'll talk about some of the research I did as a postdoc at the University of New Mexico. I currently have no disclosures. I'm not invested in any of the companies that I'll talk about today, and I'm not making any money off of this research.
Jay, sorry to interrupt. I actually do not see your screen.
Oh, what do you see?
I just see your face.
Okay, well, you can look at my face the whole time if you want. Let me try this again. How about now?
We're getting there. We see the presenter view of your presentation now.
Well, maybe by 1 o'clock we'll get there. Let's see. Okay. I apologize. I have multiple screens, so it's difficult to figure out which screen to share sometimes. How about now?
This looks good, although I feel like we're only seeing part of the screen, but maybe that will become clear. Yes, it looks good.
Okay, cool. Okay, so there's the disclosure slide. No disclosures to talk about. So what I wanted to do, since this is a talk to, since we have a lot of neurologists on the call, is I first wanted to outline what focused ultrasound neuromodulation is, and why we think we can use it to perturb the nervous system to understand neural function. And then I want to talk about how we've used this technology to enhance well-being. This is in the context of mood regulation and depression. And finally, we'll talk about our current research, which is all focused on accelerating mindfulness training and using focused ultrasound as a means to accelerate that training. So what do we mean by perturbing the nervous system or perturbing the neural systems? Well, there's obviously many different ways to do that, and each of these waves are very important for understanding how the brain functions. So my dissertation work was all on visual neuroscience, where we typically would show subjects visual stimuli, which is one way to perturb the nervous system to find out function. Obviously, you can do other things like directly stimulate neurons in a dish. Neuroscientists do this all the time to try to understand the basic functioning and the biophysical mechanisms of neurons, as well as you can give chemical interventions like caffeine, for example. But more recently, there have been two classes of technologies that have been developed really since the 1980s that have allowed you to more directly interface with the brain to modulate brain function. One of them actually involves invasive surgery. So they're actually doing this in humans, where they inject or surgically implant electrodes down into the brain, typically as a treatment intervention for things like Parkinson's disease. However, these are also very useful tools for trying to understand how the brain functions, because you can selectively and causally activate brain areas. The more recent invention has been non-invasive brain stimulation technologies. These, thankful for the subjects, you don't actually have to do any neurosurgeries or drill holes in the head, but you're using some type of energy. It's usually direct current, electricity, or very strong magnets to actually perturb brain areas for a very short amount of time. And these have been very popular technologies as of the last 20 years or so. So obviously, all of these methods have been useful for perturbing the brain to understand basic brain function. So we're talking about how the brain processes information, all the way down to the biophysical mechanisms of neurons, as well as trying to build theoretical models for how the brain and how the networks of brain areas function together. But once you have that basic understanding, then you can use these technologies to actually create treatments. So now if you have neural targets and you have a way to reliably stimulate or inhibit those targets, for example, with non-invasive brain stimulation, then you can actually invent treatments that are effective. For example, for Parkinson's disease or Alzheimer's disease, which are being currently developed. So today, what I want to focus on are non-invasive methods of neuromodulation, and I'll show you how we're using that to treat well-being or to enhance well-being. The most popular form is transcranial direct current stimulation. So basically, this involves putting 2 electrodes somewhere on the head, dipping them in a little saline solution, and then injecting a tiny amount of direct current across the scalp. There's thousands and thousands of studies of this. It's been very important for understanding brain function. But the more powerful technology actually involves magnetic stimulation, where you're actually putting a very strong magnet right up against the scalp, and you're inducing a magnetic and an electric field in the brain so you can modulate and perturb brain function. This is called TMS, and TMS has actually been approved recently as a treatment intervention for depression. Now what's interesting about that is it works just about as well as something like Prozac, so the SSRIs for treating depression. However, with TMS, because it can be relatively focal, as you see in the picture here, you can actually target very selective brain areas, and you don't get all the negative side effects that you get with something like Prozac. It works actually about the same effect size as Prozac, to be honest, about 70% of patients. So these technologies really are, you know, once we get them cheap enough to get them out into the clinics, they're actually very useful for actually replacing some of the more crude chemical interventions or pharmacological interventions. Now, when we turn to ultrasound and thinking about using ultrasound as a tech, it's actually a highly developed technology. It's been in practice for over 80 years. When you're using low intensity ultrasound, you can do all kinds of interesting things like image pretty much any place in the body. It's used routinely for therapeutic interventions, for example, for athletes, treating bone fractures and muscle issues. And so it's been a highly developed technology. Actually, this little device you see here, it's called the Butterfly, which is an imaging device that hooks into your iPhone. And this is about to dramatically change the imaging ultrasound field. Actually, this is $2,500. So as far as the technology goes, it's been very well developed. And we also know that if you use higher intensities of ultrasound, you can actually destroy tissue. So of course, you can get ablation on kidney stones, for example. And there's actually a group called Insight Tech out of Israel that have developed an MRI-compatible ultrasound helmet. So that's what you see here. Has about 1,000 sub-element transducers that focus a beam of ultrasound all the way down to the thalamus in the brain. Now this is in the MRI. This is not requiring any surgery. It's non-invasive. But you can actually heat up cancer tissue with sub-millimeter precision, and you can destroy that tissue without surgery. So the technology has obviously been very highly developed. And the question now is, if you could use this technology to actually perturb the nervous system, it would open the door for a whole new level of therapeutic interventions, as well as a tool to study the basic functioning of the nervous system. So you're probably going to be surprised to learn, actually, that we've known that ultrasound can actually perturb the nervous system since about the 1920s. I could spend a whole talk sort of talking about that interesting history, but one of my favorite studies is actually from William Fry, one of my favorite researchers. And back in the 1950s at the University of Illinois, he was doing all kinds of fascinating ultrasound research. So here's a case where he's actually perturbing the visual system with light. So he's stimulating the cat visual system. And he's recording evoked responses. So this is an EEG, and this is just a standard evoked response. Now, what he did is he sent an unfocused beam of ultrasound right into the thalamus, the sensory relay input to the thalamus. And the question was, can you actually modulate sensory inputs in the thalamus relative to light stimulation? And that's exactly what he showed. So right after the ultrasound to the thalamus, he actually reduced the amplitude of a visual evoked potential. And importantly, that goes back to baseline after about 30 minutes. So, you know, going back as far as the 1920s, we've known that ultrasound can at least have these modulatory, these temporal modulatory effects on the brain. Oops, sorry about that. However, in about 2008, my collaborator Jamie Tyler, or William Tyler, published a really groundbreaking study where he actually showed that in a dish, you've got a neuron in a dish, and you're measuring its firing rate. If you send a pulse of ultrasound, so these are micro pulses of ultrasound, into that neuron, you can actually cause the neuron to fire. You can cause an action potential. And you actually see five spike trains occurring. So these were 5 pulses of ultrasound, and you get 5 spike trains. So this really got the attention of the neuromodulation field and other scientists as well, because now it not only showed that you could modulate neural function, but you could actually immediately evoke neural activity, so you could provoke brain activity. So this really sort of made the field explode, I think. And this is actually from Jamie's YouTube page. So right here, you're seeing a focused beam of ultrasound targeted right to the middle of this dish of neurons. They're stained with calcium stains, so when they express their calcium transients, you actually see them fluoresce in green. And here's what you see. So there's the pulse of ultrasound, and now you see the sort of spreading activation of those neurons. It's a pretty clear demonstration. So Dr. Tyler started putting out studies like this. This really sort of got the field re-interested in using ultrasound as a perturbing tool of the nervous system. And then a whole bunch of studies started coming out in the mid to late 2000s. One of my other favorite researchers, Sunchik Yu at Harvard, published some really fascinating studies back in the 2010s, where he was actually showing that you could focus a beam of ultrasound into very specific and highly focal regions of animals' brains. So here, this is a rabbit who's in the MRI scanner. So this is one of the advantages of ultrasound. You can do this concurrently with MRI. And then they're basically focusing the beam of ultrasound into the motor cortex of these animals. And the question first was, can you basically activate the MRI signal of brain activation called BOLD, which they showed. So here you see motor activation in the rabbits. And then they basically showed that you could cause actual motor movements. So by targeting the motor system in a rabbit, you could actually cause the little paw, I don't know if you can see here, but that paw is twitching from B to C. So this is a really clear demonstration that not only is ultrasound able to provoke brain activity, but it can be highly focused to very specific representations in the brain. Now, importantly, when you're thinking about doing this on your own brain, or when I think about doing this on my brain, you want to ask, how safe is this? And most of the animal studies in the early 2000s were looking at histological analysis. So they unfortunately have to sacrifice these animals. And then they slice the brain to look for evidence of any damage. And basically across all of the studies, if you're using low intensity ultrasound, you don't see any microvascular damage or anything like that. There has been one study coming out of Harvard that showed if you do the pulses very quickly in a short amount of time, you can get microhemorrhaging. And so there's a really important caveat that the way that you pulse the ultrasound is crucial for safety. And so typically we're doing 1 or 2 pulses a second and spreading that out over time. And when you do that, you don't see any detectable damage on the brain. So there was sufficient animal research to cautiously suggest moving into human research. And so several labs have actually done this in humans now, including ours. So basically, we're looking at a single ultrasound transducer on the side of the head. These subjects are in the scanner, and this is a model. This is actually a beam model. And so basically, this is what a single beam of ultrasound can do if you can get it focused through the skull. This team is actually focusing on the thalamus, so they're trying to modulate thalamic activity. And the basic idea was, can you modulate sensory information, much like that the cat study I was showing you earlier. And basically, if you stimulate the hand, you get a somatosensory evoked potential in the EEG. It looks like this. And basically, they showed in red, if you ultrasound into the thalamus, then you can actually reduce the amplitude of that evoked potential, that somatosensory evoked potential. So this basically is just replicating the old research from the rabbits, but now doing from the cat, but now doing that in humans. And again, this was done safely in humans. There were multiple subjects who went through this study. Now, I just quickly went through yesterday and looked at the number of publications that are coming out with focused ultrasound neuromodulation. Going back to 2015, you know, it started in way earlier than this, but you can sort of see that now there's been a sort of explosion in the literature, and this is 2020 and we're only halfway through, and now, you know, we're already above 2019. So this is becoming very interesting for a lot of different researchers for both basic neuroscience and also for clinical interventions. And so far there's been about 14 human experiments done over hundreds of subjects, including we've run 200 subjects in our lab with no negative incidences with low intensity ultrasound. So this is another slide that I like from Dr. Tyler's lab that really compares the focal specificity of all the non-invasive stimulation modalities. So this is direct current, and you can actually see where the pad would be worn on the scalp. This is the brain, of course, but the pads are on the head. And you can actually see that the current spreads between one pad and the other pad on the head. With magnetic stimulation, it gets much more focal, but it's still, you're talking about tens of millions of neurons being stimulated by magnetic stimulation. And theoretically, if everything is perfect with your focusing of your ultrasound through the skull, you could actually focus to sub-millimeter, well, at least millimeter precision at this point, which Dr. Tyler's lab has actually demonstrated as well as others. So it really shows the benefit of ultrasound. If you can get it across the skull and you can focus it into the brain, you're really talking about a magnitude better resolution. However, I want to give a caveat to that most of the studies that you will see so far, you know, we're showing beam models where the transducer is on the outside of the head. We're focusing the beam deep into the skull, which is an advantage. And a perfect ideal world would look like this. If you're not actually correcting for the skull aberration, so the skull is sort of changing the ultrasound beam as it's moving through, your beam in reality is looking more like this. So most of the researchers at this moment are probably looking at some type of sort of opening of the beam and multiple side lobes on that beam. And so this is an active area of research, but you know, this is kind of the beginning stages of this field. And so at the moment, until you correct for the individual skull, really it's not nearly as focal as we would hope it to be. We could talk about potential mechanisms for a couple hours, so I'll just outline the basic ideas of why we think ultrasound may be influencing neural activity. Most of the evidence so far is either for radiation forces or for cavitation. So radiation forces are basically like acoustic radiation forces that could be acting across the lipid bilayer or the membrane that's actually causing it to change its capacitance. There is some slight evidence for that, but much more needs to be done. There's a cavitation model that's actually saying that you're moving small microbubbles. They're stable, so it's called inertial cavitation. But that movement of those microbubbles is actually changing the conductance within the lipid leaves or the lipid bilayer. And there's a model for this that comes out of Israel, and there's a little bit of evidence for that as well. And of course, since we're using mechanical energy, it's possible that we're heating up the system, which is changing its behavior. Now, we're using such low intensity ultrasound that it's unlikely that we're heating it all that much, but even small amounts of heat may be changing the conductance properties of the neuron. And then when you sort of focus into the biophysical mechanisms, there's a lot of different ideas floating around out there, but we do know that the ion channels have a sensitivity to mechanical stretch, mechanical force. So if you move the membrane, those ion channels can open. There's actually ion channels called piezo channels, like piezoelectric crystals. So clearly we know that the ion channels can respond to mechanical force. But the mechanism, much like with TDCS and TMS, is very much unknown at the moment. And really, we're not going to be able to totally accelerate the field until we understand these mechanisms. So with that, I want to sort of move to the research that we've done. But I will say ultrasound is a very fascinating technology, but it's not quite at the level of something like TMS. So like I said, TMS can actually cause motor potentials. If I have a TMS on your motor, over your motor cortex of your scalp, I can actually cause a finger movement. You can do that in animals with ultrasound, but it has yet to be demonstrated in humans. And I think a big reason for that is actually it's really hard to get the focal beam across the skull. And so ultrasound is still sort of in the early days. We can't quite even compare it to TDCS at the moment, especially not TMS, but it has the potential to get there and actually surpass it in the future. So with that, I want to turn to some of the research that we've been conducting with ultrasound stimulation. And this really started back in 2013 with my collaborator, Stuart Hameroff, who you see here. Dr. Hameroff runs the Center for Consciousness Studies and has a theory of consciousness that has to do with microtubules, which is totally separate research. But Dr. Hameroff was reading some of the literature that Dr. Tyler and others were publishing, and he started wondering, well, okay, we have these ultrasound systems sitting around the clinic. He's an anesthesiologist. What happens if I put one of these devices up on my own head? Can I actually change my conscious state? And so he actually conducted one of the first studies in humans, and I think actually the first clinical trial, where he actually took chronic pain patients and asked if he could modulate circuitry in the brain that deals with pain perception. So what you're seeing here is a group of pain patients who got ultrasound treatment. This was with a diagnostic ultrasound, literally just sort of plopped on the head like you see here, relative to placebo. And what they found actually is that in the treatment condition, ultrasound actually reduced pain perception slightly. It was not significant, it was 0.07, but it was suggestive that this might be a type of intervention that would be pretty easy to use. What they did find, though, is that you can increase mood over about a 40-minute period. Now, with chronic pain patients who are in the clinic, many of the people out there probably work with these patients, you'll know that it's very hard to increase affect and general mood in these people. They're pretty cranky, you know, they have chronic pain all day, and it's very hard to get an effect like this. And so we looked at this research and we wondered, well, are they increasing their mood because the pain is decreasing, which would increase mood, or are they actually stimulating mood circuitry directly in the brain? And that's really our entry point into ultrasound as a stimulation technology. And so we decided to try to replicate that experiment, but now with healthy controls and sort of a better controlled experiment. We decided to target the right inferior frontal gyrus, which is really an inhibitory control hub in the brain. It controls sort of inhibition behavior. And we really wanted to know, is the right IFG involved actually in mood perception as well, so modulating mood, or is it just involved in sort of basic behavioral inhibition? There was some evidence to suggest actually the latter, that it's involved in mood. And so we did a very basic paradigm where we took mood scales and actually some psychophysiological measures. Then we did an ultrasound stimulation for 30 seconds with a diagnostic ultrasound. And then we just asked people to rate their mood again, sort of 3 times after that. And lo and behold, what we found actually is that using diagnostic ultrasound to the right inferior frontal gyrus, you can actually significantly enhance mood in healthy subjects. So the way to read this scale is that as you move up the scale, you're reporting better affect, happiness, less sadness, sort of better overall mood. And as you see in the placebo condition, there was actually no change from baseline. So this was very exciting to us. This is a very simple ultrasound device that we can get from any hospital. And now it suggests that we have a target actually for enhancing mood in people. And so right IFG TUS transcranial ultrasound enhances mood. Then we started wondering, okay, so this is sort of interesting. These ultrasound imaging systems are used all throughout the world. Are we really sure that they're actually modulating the excitability of brain activity? And so we borrowed a paradigm that comes from the TDCS literature, where you're basically using a magnetic stimulator over the motor cortex to cause a motor evoked potential. So you have two electrodes, you're measuring finger movement, and you're provoking that with TMS. Now, it was found with TDCS that if you measure the baseline amplitude of a motor evoked potential, you can actually change the amplitude relative to which pad of TDCS you use. So, right, they have two pads, the current flows one direction or the other, and basically they find with one pad, you could actually increase the excitability of the motor evoked potential above baseline for about 3 to 4 minutes with TDCS. If you switch the pads and now you put the other pad over the motor cortex, you can actually reduce the excitability of the motor cortex and the motor evoked potential below baseline. So this really was the first study to kind of make the TDCS field explode. And we basically asked, can we do the same thing with ultrasound? So we get a nice baseline with magnetic stimulation of evoked potentials. Then we do ultrasound for 2 minutes over the motor cortex. And we ask, just like this, do we see a change in the excitability of the motor evoked potential? Here's the placebo condition, there's no change. And then when we actually use real ultrasound over the motor cortex, we actually increase the excitability of the MEP, of the motor evoked potential. So this was actually really good evidence for us that actually these diagnostic ultrasound systems can get into across the skull, which is a very thick piece of skull up here at the top, and they can actually modulate the excitability of the motor system for at least 6 minutes or so. So actually on the same time scale of TDCS. Now that's exciting for us because if it's possible to actually use these diagnostic systems for perturbing the nervous system as well, that opens up a whole new field for using diagnostic ultrasound to actually modulate brain function. But we didn't want to stop there. Of course, the advantage of ultrasound is it can be focused. And so when I was a graduate student, we teamed up with Jamie Tyler and his company he had at the time, was called Neurotrek, which became Think. And they basically loaned us a focused ultrasound device. So this is the focused ultrasound transducer. And this is basically how small these devices can be made. So Jamie really did a beautiful job of shrinking this device down and making it portable. And we asked, can we replicate that mood effect? So can we focus a beam of ultrasound right into the right inferior frontal gyrus? And can we actually get that mood effect again? And we were actually hoping to get a bigger mood effect because now we're using focused ultrasound. So the basic finding is that we replicated that effect with focused ultrasound. We increased mood. The effect was actually not quite as big and the variability actually increased. That's a bit of a mystery for us. But relative to placebo, again, we can actually modulate the right inferior frontal gyrus and we can lead to positive state changes in our subjects. So again, this was exciting and we got to replicate that effect. Now, we didn't want to stop there. However, we were still sort of being skeptical of our own results and asking, are we really getting ultrasound across the skull and into the circuit, the brain area and the circuit that we're really trying to target? And so we did a fMRI ultrasound study in humans where we did pre-post, so pre-resting state fMRI, so you can look at the network connectivity in the brain. And then we just simply wanted to ask, can we change network brain activity? So these are kind of complicated graphs, but basically you're looking at the right IFG as a seed, and we're looking at what is the right IFG connected to. So what's it sort of friends with in the brain? And this is sort of what you see in the brain of a normal subject at baseline. Now we did 2 minutes of ultrasound outside of the scanner, and then we put people back in. And now, relative to our stimulation target, you see massive changes in connectivity. And specifically, this is decreased. So the right IFG is now decreasing its connectivity with a bunch of very interesting brain regions that are involved in mood and emotion regulation. This was actually a very big effect. These were 9 or 10 subjects. So to get such a big sort of significant effect in a small group was very significant for us. And basically this is what we find. So if we look at the right IFG where we ultrasounded and we look at all the brain changes, the overall story is that we decreased activation in areas that deal with salient emotions. So you might guess, well, if emotions become less salient, people might feel better. They're sort of dealing with less negative emotions. And then we increased to the orbital frontal cortex, which has to do with cognitive control. And so we're sort of decreasing the salience of negative emotion, and we're increasing the control over the emotion regulation system. So this was actually a very surprising effect for us, and we're very happy about that. We then did some acoustic modeling. We still wanted to go further and ask, where's that ultrasound actually going in the brain? So this is for a representative subject, and basically what you can see, the transducer is heating up the skull quite a bit, but that's still a safe level of heating. And then this is sort of the focal beam, which is a little bit longer actually than we were expecting. And then finally, we didn't want to stop there. We wanted to ask, can we actually use this as an intervention for depression? So now we have a target for mood, and we wanted to bring in depressed patients and ask, over 5 days of stimulation, can we actually reduce depressed symptoms or depression symptoms? And so depressed patients came in, they either got real or placebo stimulation for 5 days, and then they had the option to come back. If they were in the placebo condition, they could come back and get the real stimulation later. And the basic idea was to replicate that mood effect and then look at EEG as well. Because we were doing multiple days of stimulation, we actually reduced the overall intensity of the ultrasound, because we wanted to be extra safe, which was actually a bit of a handicap for us, because I think it reduced the overall effect. But over the 5 days, we actually replicated that mood effect. So we made depressed people feel better, so their sort of happiness scores went up, but their overall depression scores actually didn't change. So that was a bit disappointing for us. And then when we looked at EEG, we didn't find any EEG markers of depression that were changing. So, that was a bit discouraging for us, although, we have a bit of a hint that we can enhance mood in these people. But partly the reason that it happened is likely because we basically brought depressed people in, we gave them a very, very low dose of ultrasound, and then we didn't couple it with any other type of intervention. And so as I started reading the neuromodulation literature, it started becoming clear that to get relatively large effects with neuromodulation, with perturbing the brain with ultrasound or TMS, you really need to couple that with some other type of intervention. So if you're treating depression, you really need to couple it with cognitive behavior therapy. And then you sort of get an interactive effect where the circuitry that you're stimulating or inhibiting with brain stimulation is sort of being taken advantage of by the other interventions. So, I started sort of looking down that path and really thinking, what types of interventions would we really want to couple with ultrasound to get a much bigger effect? Now, I'm a long-term meditation practitioner. I really was starting to already sort of pivot my research to mindfulness and meditation research in general. And so I really started wondering, could we couple focused ultrasound stimulation with mindfulness training? And then I ran into this guy, Shenzhen Yang, who Rael mentioned at the beginning. He's a very famous mindfulness teacher and really a science geek. He has a really good sort of mind for science and mathematics. And I started sort of talking to Shenzhen about some of his ideas about coupling neurostimulation with mindfulness training. Shenzhen had been thinking for a long time that you could actually accelerate mindfulness training by targeting certain neurobiological subsystems in the brain that are involved in learning mindfulness. So Shenzhen and I met when I was a postdoc. We started really geeking out together about these ideas. And I really started getting excited about this because if you really look across the mindfulness literature, it's a very young literature as well. And although it seems like mindfulness is very sort of positive for affect, emotion regulation, and just general health, we really don't understand much about the sort of neurobiology of mindfulness and what's really happening in the brain as someone changes with mindfulness practice. And so really we started wondering, can we use this tool of ultrasound to perturb the systems in the brain that we think are involved in meditation and mindfulness to understand how it works? Once we understand more about how it works, can we actually use those targets to accelerate mindfulness practice for clinical interventions? So that was kind of the big idea. And really what we were interested in is this idea of, can we take something like a mindfulness state? So typically you're doing some mindfulness training, you're inducing a certain state of calmness or focus, for example. And over time, the reason that this tends to work in the clinic is you go from state changes to trait level changes. So if you have something like chronic pain that you're dealing with and you apply mindfulness to that problem, you can induce a state of sort of acceptance of your pain such that it doesn't cause you to become angry at your pain and sort of go down that spiral. But that state change can lead to a trait level change over time, where even though you may have chronic pain for the rest of your life, you're starting to sort of change your disposition towards that chronic pain. And so Shinzen and I really wanted to know, what are these brain states, you know, that mindfulness is inducing? Can we do something with focused ultrasound to mimic those states and understand them? And then can we use the protocol to actually reduce the amount of time it takes to go from state level changes to trait level changes? That's the basic idea. And so the reason we thought that this might work is because I actually had a tiny bit of evidence that we could stimulate a part of the brain that's involved in mindfulness to actually induce a state. So this is the anterior cingulate cortex down here. And we had actually done a small pilot study where we attempted to stimulate the ACC in a group of just healthy people, non-meditators. And the basic finding was that we could actually induce a mindfulness-like state for about 30 minutes in people who were simply just sitting there, they're not doing any type of mindfulness practice. So this was the baseline measure of mindfulness. This is the scale of mindfulness. And after the ultrasound, we actually just induced a state of present-centered awareness. In the baseline condition, there was really no change or reduced slightly. So, you know, Shinzen and I were looking at this and other things, and we were thinking, okay, this is pretty interesting. Can we actually try to sort of find the real systems in the brain that are involved in mindfulness training, and can we modulate those with ultrasound to induce these states and try to induce these trait level changes? So let me back up a little bit and just define what I mean by mindfulness. It is actually multiple constructs, and it's multiple things depending on how you're talking about it. It's actually a form of awareness, so it's a form, it's a sort of state that you can get into, and it's also a set of practices that you can use to alter your awareness. The typical definition is that it's present-centered, non-judgmental awareness, so it's something about having a sort of attentional focus in the present moment and doing that in a non-judgmental way. But that's a very hard definition to operationalize and sort of quantify in the lab. And so one thing I really like with working with Shinzen is he's actually outlined a more sort of definitional way to think about mindfulness such that we can study it with behavioral tasks in the lab. And so the take-home message here, I don't have time to explain it, but is that mindful awareness is really composed of sub-attention skills, and that these attention skills, either independently or especially working together, are what create what we're calling mindful awareness. And when you bring those attention skills together online and apply them to something like chronic pain, that's why you actually get this sort of behavioral effect in the clinic. That's how you get to behavior change, and ultimately that's how you get to people feeling better in the clinic. So we'll focus on equanimity today, which is the one that we're really trying to induce in the lab. And you can think of equanimity, it's sort of a balance beam here. So it's sort of mental balance, which I know doesn't really explain it to you at all. But you can sort of think about it like a dispositional state to being mentally cool. So cool, calm, and collected, independent of what's happening in your sensory world or in your body. So if you take the person with chronic pain, for example, if they're learning equanimity practice, and they apply that equanimity to their chronic pain, they are sort of fully immersing themselves in the pain perception. They're not repressing it or pushing it down. They're not sort of getting spun up by the pain and sort of getting angry at themselves for having chronic pain or whatever may happen. They're witnessing the pain. They're sort of focusing their attention on the pain. And then they're being, quote, non-judgmental, if you want to think about it like that. They're sort of allowing the pain to be there and then reapplying their attention to the present moment. So it's this sort of baseline sort of mental coolness, if you want to think about it like that. And then equanimity is sort of working with the other attention skills to help you deal with something like pain in the present moment. And so the idea is that you train on these mindfulness skills, these attention skills. You then apply those skills to the present moment, whatever's happening. So if you have pain, for example, you apply it, you notice your pain, you say hello to your pain, and then you try to let that pain subside. So instead of repressing the pain, instead of sort of getting sort of spun up by the pain, you notice that the pain has a peak sensation, and then that pain sort of goes back down to baseline, and then maybe it comes back and it keeps doing that. But if you're applying your attention skills to that over time, the pain sort of subsides and you break the behavioral chain to getting sort of wrapped up in that pain. So if you have anger issues because of your pain, you may break the link to those anger issues. Over time, then that leads to well-being changes, which then loops back in and makes you want to do the mindfulness practice more. And so that's a sort of general overall mechanism for mindfulness. Now, what we started asking is, can we actually induce some of these states in the lab, like equanimity, and can we actually induce them while people are learning the mindfulness skills? So Shinzen and I launched a lab where we're actually trying to do this currently, called Sonication Enhanced Mindful Awareness Lab, and that's sort of the current paradigm. Now, we really focused on two networks in the brain that we think can be our sort of hubs for equanimity. And really, we think that they're actually non-equanimity hubs. So we think they're actually interfering with equanimity, and if we can slightly reduce their activation, we can actually give a person the sense of equanimity, and they can train into that practice. So one's the default mode network, which deals with self-processing and sort of self-interference, and the other one's the cortico-basal ganglia habit formation system, which we've actually targeted both of these with ultrasound. And both of these deal with equanimity in different ways. One's sort of you're getting in your own way with the default mode network. This one is sort of the habit formation system, the sort of craving system that causes you to sort of automatically behave when you need to actually break that automatic behavior. And so first we decided to target the default mode network with ultrasound, and we basically wanted to ask, can we induce equanimity within the default mode by suppressing default mode activation? So very briefly, the default mode activates when you have all kinds of self-referential processing. So if you're thinking about the future or you're thinking about the past, you'll see default mode activation. And it's really these midline structures, particularly this one in the back that we're interested in, called the posterior cingulate cortex. Now, of course, the default mode network is a hub of hubs, and there's multiple networks within this system. But we know enough about the default mode network to suggest that if we could inhibit this major hub, which is basically this one here, that we might actually be able to temporarily down-regulate that whole network. Now, why would we want to do that? Why do we think that has something to do with mindfulness in the first place? Well, there's been lots of studies of meditators now in the scanner, in the MRI scanner, where you're looking at what's activating and deactivating while someone applies the practice. And one of my favorite studies is from Judd Brewer, where he had long-term practitioners in the scanner, and he's basically acting what's deactivating when a person is applying a practice, and then what is changed in the network when you just look at it at rest. And so basically during practices, these are different types of meditation practices, you see a massive decrease in the default mode network for meditators relative to controls. These are people who just learned how to meditate. So that's suggesting that there's some long-term change in this network over time that's really being affected by mindfulness intervention. Now, if you look over in another interesting literature where they're actually giving people psychedelics for clinical interventions, you see a very similar story. So if you give someone psilocybin, which is magic mushrooms, and you let them undergo a clinical intervention to reduce something like depression, you see that same area in the default mode deactivating below baseline. And what's really interesting about that is the more deactivation in that hub, the posterior cingulate, the more you get what's called an ego dissolution. So the more the sense of self really sort of dissolves to the point of a huge clinical outcome. So ego dissolution basically predicts in someone who has PTSD, for example, that they will have a positive clinical outcome for 4 weeks or so. These are these subjects out here in time. So the more you deactivate that default mode network, the more you can predict something like ego dissolution. Now, you might think that what's happening underneath is actually equanimity, that by down-regulating this network and giving these patients or meditators the taste of having that network less interfering moment to moment with experience, that you're actually increasing equanimity in day-to-day life. People with PTSD are still experiencing some of that trauma, but now they have this new tool of equanimity where they can witness it without getting sort of spun up into this sort of emotional experience that they normally have. So the psychedelic literature sort of maps onto the mindfulness literature, which is quite interesting. And with that, we really wanted to ask, okay, what happens when we take a group of non-meditators and we inhibit the default mode network, specifically that back hub in the default mode network? Can we induce something like a state of equanimity? And can we actually down-regulate the default mode network connectivity? That was the first question. We did this in a pilot study a bunch of months ago now. Sorry, time is going by really fast. A bunch of months ago, at the end of last year, in 6 subjects. These are non-meditators. And we basically asked, before and after getting an MRI, can we down-regulate the default mode activation? And then does that map onto a phenomenological experience of a subject that seems in the direction of equanimity? And so we gave a scale to these folks who got this intervention that has a concept called decentering, which is sort of similar to equanimity. And then we gave them 10 minutes of ultrasound after getting a baseline MRI. And then we basically asked them a bunch of questions about their current mental state. And what you see is at baseline, people have about an 8 of decentering, which I know is totally meaningless to you, but that's sort of a normal level of equanimity. And then after the intervention, we had a slight but significant increase in equanimity in these patients, or in these subjects. Now, this was not a controlled study, so this was just a one-off of 6 subjects. But when you actually talk to these subjects, they reported things like either an equanimity state or a flow-like state. That happened in the scanner. It happened for about 10 minutes for each of these people. It was highly pleasant. They were sort of out of their own inner talk space, and they were sort of present in the scanner. And they all really enjoyed the state. So it sort of suggested it was inducing an equanimity-like state. Then when we looked into the default mode network, we found massive decreases within the default mode network and also decreases in other prefrontal areas. So we're seeding the posterior cingulate, the back hub of the default mode, and we're looking at what has changed after getting ultrasound. And basically we see the whole path of ultrasound has basically changed. That's the precuneus, and that's the posterior cingulate of the default mode network. So we got a massive decrease in the default mode, which is actually the first time anyone has ever shown something like this in healthy subjects with any type of brain stimulation. And then now what we're wanting to ask actually, does the magnitude of each individual subject actually map the magnitude of their self-report? That's what we're looking at right now. We actually replicated this in another group of subjects with EEG, where we asked, can we change EEG measures of the default mode as well? So if you have an EEG cap on and you're looking at the default mode activation, you actually see enhanced alpha, so 10 hertz of EEG when a person's in the default mode activation. And so basically, again, what we found is that relative to baseline, you see very normal alpha activation, that's 10 hertz. And this is actually within the 2 areas of the default mode, medial prefrontal cortex and the posterior cingulate. And again, in another group of subjects, this was 15 subjects, after ultrasound into the default mode network, we reduce that EEG measure of default mode activation as well. And we went even further and we looked at the connectivity between the 2 hubs of the default mode network. And we found again that we're reducing the connectivity. So it really maps onto this idea that the ultrasound is at first getting across the skull. Some of that ultrasound energy is actually inhibiting the hubs of the default mode network, and it's disrupting the activity for a short amount of time. Both of these deactivations lasted for about 10 minutes or so, maybe up to 15 minutes. And then subjects states kind of went back to baseline after that. So this was very exciting to us. It's a very small group of pilot studies, but it's very suggestive that we might actually be able to reduce the default mode activation. So then we wanted to turn to our other brain structure, the basal ganglia. So you're probably surprised, especially the neurologist in the audience, to learn that we were actually ultrasounding the basal ganglia to try to inhibit for a short amount of time. But that actually came out of some disorder that Shinzen was reading about called athymorrhea, which is basically a bilateral disruption of the cortico-prefrontal thalamic basal ganglia loop. So typically it's damage to the caudate nucleus or the head of the caudate nucleus, but it can be anywhere along the loop, but it has to be bilateral. So only a handful of subjects in the world actually get this disorder. And basically what happens is you get an extreme disorder of motivation. So these subjects basically lose all motivational capacity such that they never move. They come to the office, they come to the lab, they come to the clinic, and they literally just sit there and stare at the wall until you activate them. It's a super fascinating disorder of consciousness. But what happens to them is they actually, they sort of lose their ability to act on something like a pain signal. So these patients will be totally aware of pain if they get a finger prick or something like that, but they actually won't activate on that pain at all. And they'll make claims like, well, I noticed the pain, but it really didn't cause any sort of reason to move because I wasn't suffering. And so we looked at this as basically highly pathological, but as a model for equanimity. And we started thinking if we could temporarily inhibit the basal ganglia, we might actually be able to induce equanimity for a short amount of time so subjects could learn that. I know we're running out of time, so I'll just show this really quickly. There's not a lot of evidence that you can get ultrasound all the way down to the basal ganglia. There's a bioRxiv paper that suggests in at least a patient or two that you can. But we actually tried this in Shenzhen in a series of subjects where we basically asked, okay, if we take a group of very experienced meditators and we try to inhibit the basal ganglia for a short amount of time, does that lead to these equanimity-like states? It turns out in Shenzhen, all day we can induce this state, and it's a very strong effect. But of course, Shenzhen is biased, he's working in the lab, and so we had to replicate that. So we took a pilot group of 5 long-term meditators. We used neuronavigation, so we could stimulate right into the bilateral basal ganglia. And we did a 4-day protocol, and the basic effect replicated our default mode study, actually. You'll notice that the measure of equanimity in long-term meditators is much higher than controls. But again, we found a significant effect where we could induce equanimity in these patients. And so that is suggestive that the basal ganglia is involved in more than just habit formation and stimulus response, but it's actually involved in this construct of equanimity as well, and that we could actually induce it in the lab. And so this is sort of our current getup, or our current setup that we're using in the lab. This is Shenzhen modeling this. And really what we're gearing towards now is recording EEG in real time while people are learning meditation. So we want like a 1 to 2 month protocol. They get maybe 2 ultrasound sonications a week, and they're actually getting they're getting meditation protocols piped in through the headphones in real time. And so that basically allows us to assess how the brain is changing with ultrasound, as well as do cognitive assessments to make sure that we're not leading to any negative sort of deleterious effects on the other cognitive systems. So that's very exciting for us. That's the 2-week protocol. And really what we want to ask is, can we understand the neurobiological substrates of these meditation states by inducing them in these different brain areas? And then can we understand how you go from the state level changes to the trait level changes? Once we have a model for that, can we actually use ultrasound to reduce the amount of time it takes to go from state level changes to trait level changes? Now, if we can do that, which is, I think, going to take several years, if we can get lucky in this research, then we can actually use this paradigm as a clinical intervention that can treat things like chronic pain, addiction, all the way up to things like depression. And we can take protocols that typically take 2 months to get a clinical outcome, and we can shrink that down to maybe a month or maybe 2 weeks if it's powerful enough. So that's the basic overall paradigm. I think I've gone over the time, so I will come to my thank you slide for all of our collaborators and our research assistants. And I just want to thank you for listening. So will we take some questions? I guess people can stick around if they want to.
Thank you so much, Jay. Let me ask our neurology hosts to let us know what you'd like to do. I understand with the clinic schedule, maybe some people have even had to leave already or are having to leave now. But if you'd like to make some final comments related to any housekeeping for the Department of Neurology, you can chime in now.
Oh, you're on mute. We can't hear you. Maybe I can unmute you. There you go.
Hi, we could take some questions. I don't know if anyone has any questions, or I think we can take a few minutes.
Sure, I'm happy to.
Thank you so much. That was wonderful. We really appreciate it. It was so interesting.
Thank you.
It looks like we do have a few questions. I'll start with Robert Lawson.
We might have to unmute people from our side.
I'm unmuted, thanks. So Jay, awesome. So what have you seen about other modalities for reducing activation, say infrared or magnetism? Transcranial infrared or transcranial magnetism.
Are you talking about specifically in like the default mode network or the basal ganglia?
Yeah, let's say default mode network.
Yeah, for the default mode network, Judd Brewer has actually done some really interesting work with neurofeedback. So this is an EEG paradigm where you're feeding, you're doing biofeedback basically with the EEG. And he's actually had some success doing that. Also Fmri neurofeedback. So he had people in the scanner, and he's actually reading Fmri activity in near real time and feeding that back, specifically about the PCC. So that's very promising, although getting that to work outside of the lab is quite difficult. As far as something like TMS or TDCS, the problem is it's very hard to get electricity and magnetism to these deeper structures. So that's one of the big advantages of focused ultrasound. If you can get it, focused across the skull, you can actually target these deep structures. So for TDCS and TMS, there hasn't been much around the sort of equanimity hubs, as I was calling them. But there is a TDCS protocol by one of my friends and collaborators, Bashar Badrin, from South Carolina University. And he's got a TDCS protocol where he's targeting the prefrontal targets, which are also involved in sort of top-down attentional control. And he actually has a device and a company out around that. So there's things like that. But to get to what Shenzhen and I think would be these really, really powerful effects, we think we need to get down to these deeper hubs in the brain. And you really need either brain surgery or fMRI neurofeedback or chemicals like psychedelics or 30 years of meditation to get that deep.
Great, thank you.
Let me just say, for anyone who is wanting to ask a question, there's an option in the lower kind of bar of your screen. I think it's where there's 3 little dots and a more. But we do have at least one more person who's waiting to ask a question, Felipe Jane.
Hello, can you hear me?
Yes. Yeah.
Great. Jay, such an interesting talk. Thank you so much. Really terrific. I learned a tremendous amount. I'm a psychiatrist at Mass General and a depression specialist, and I found myself very intrigued by your results with depressed patients and improving positive mood, because anhedonia is such a difficult symptom to treat, and many of our medications actually reduce affective range such that people endorse experiencing less positive mood. So if you can use a technique like ultrasound to treat either primary anhedonic symptoms or to ameliorate some of the negative effects of SSRIs. Seems to me that a lot of people could benefit from that. And so I was wondering whether in your pilot trial you had any measures of anhedonia and how you think about it.
That's a really great question. We were more interested in the rumination subset of depression, so we had high ruminators. So rumination, for the people who don't know, is sort of perseverating on negative thought, and a lot of people with depression suffer from that as well. So we really were looking at subscales of rumination more than anhedonia, but I think you're right, we should have put that in as well. I think, most of the other stimulation modalities are typically stimulating the left dorsolateral prefrontal cortex. We were going for the right lower prefrontal cortex. So we're at sort of a different target than most of the depression literature. When you stimulate the left DLPFC, you're sort of upregulating overall emotional control, which is more of a long-term therapeutic intervention than a state change like we were sort of getting here. So one reason might be that we're just sort of stimulating right prefrontal, which might have more to do with sort of current state. But that's sort of an accident of the lab that we found that, and now, like you said, we might actually be able to use that as people who are coming in with blunted affect. We could sort of give that as a short-term treatment, give them sort of a new baseline around that level, and then do left DLPFC during therapy to try to boost the cognitive control. So yeah, that's one of the other big advantages of ultrasound is unlike TMS or TDCS, you can make these transducers pretty easily. So we could actually have multiple transducers. And Shinzen and I dream of having this multiple transducer unit so we can hit multiple targets simultaneously and really try to boost multiple subsystems. There was a rat study that I saw at a conference last year, and I haven't seen it published yet, but they were comparing anhedonic model of depression in rats with ultrasound versus TMS, magnetic stimulation. And of course, when you TMS or ultrasound a rat brain, you're doing the whole brain because it's such a small brain. But what they found is that TMS does reduce some of the anhedonic qualities in the rat model, but ultrasound did so much more. So that's the only other group I've seen who's talking about something like that. But it was a poster. I forgot to take a picture. I don't even remember now where I saw that.
Well, very interesting, and I think a potentially very important serendipitous finding. Thanks again.
Well, thanks for those interesting questions, and thank you again, Jay, for giving this talk today.
My pleasure. It looks like iPad has raised their hand. I don't know who iPad is.
Oh, yes.
So I think a few people have questions. So it's a good way for everyone to click raise hand, because I think the chat function is not available right now. So I think, I don't know if Dr. Chu maybe had, yeah. So I think we're not able to unmute ourselves, it looks like. So maybe there's a function to raise hand. There you go.
Oh, thank you for the wonderful talk, Jay.
My pleasure.
I work in memory disorders, and in Alzheimer's, the posterior cingulate and the precuneus is affected early on by amyloid deposits.
Mm-hmm.
There's a loss of the synchronous on-off between the default mode network and the attention network. So normally when in an fMRI scanner, when someone's asked to do a task, the attention network goes on and the default mode network goes off. And that kind of switching is impaired in Alzheimer's.
Mm-hmm.
We kind of, in behavioral neurology, so I don't actually know what is happening to mindfulness or in patients with Alzheimer's, or how they might respond to meditation. So maybe that's another area of research. My thoughts about the basal ganglia, we think about Parkinson's, and there may be others on here from our movement disorders group, but we think about connections with the anterior cingulate and apathy. I guess you used the word athihormia. That's a tongue twister for me. I don't know if that's how you relate that to apathy or abulia, and the anterior cingulate. So it's interesting that we're talking about posterior cingulate, anterior cingulate.
Yeah, those are really good questions. I'll just say really briefly, ultrasound actually is being investigated as an intervention for Alzheimer's in and of itself. If you ultrasound an Alzheimer's brain, two studies just came out this year, you can actually reduce the beta amyloid plaques. And that's through a very basic biophysical mechanism, we think. And actually it's activating the glial cells. So ultrasound seems to have this very basic neuroprotective and neurostimulatory effect in the Alzheimer's brain. There's a couple animal models on that too, but that work really needs to be replicated before we know more. About your question about the default mode network in Alzheimer's, that's a really good question. I've been looking at all the clinical literature on the default mode that shows inhibition, because I'm very worried inhibiting the default mode network, especially the PCC, will lead to negative outcomes. You don't want to just inhibit it always over time. Now, what's interesting about meditators is you do decrease default mode network overall, but if you look at the connectivity, which is probably more important actually, the connectivity between the posterior cingulate and the task positive network, the anterior cingulate network, there's more connectivity in a meditator. So that's probably why meditators can actually task switch faster than non-meditators. And you can do all kinds of interesting task switching paradigms. But at the same time, you see less default mode overall. And so it was sort of a interesting conundrum in the beginning. Why, if you see less PCC, are they able to switch better? People think that PCC is about task switching. And that's probably because now their baseline state, their default state is actually to sort of have task positive network monitoring maybe the default mode, or maybe they're just better integrated so they can switch faster. So I would guess if you could get Alzheimer's patients to go through, a couple of years of meditation training, you would see something similar, which would actually help compensate for some of the degradation that's happening. Yeah.
If you don't mind, I would like to chime in on that, because I've thought a lot about it as well, especially early on in the resting state functional connectivity literature describing mindfulness, narrative processes, and Alzheimer's and dementia, and the kind of converging evidence around the posterior cingulate. And well, one thing, based on my understanding, reading of the literature to date, we don't have a clear sense that long-term meditation, or even the engagement with mindfulness practice over the course of a few months of gaining a skill, decreases the baseline non-meditation related state of the brain in the posterior cingulate. So the absolute activity of the posterior cingulate at baseline during everyday activities does not seem to be decreased. Maybe it is, but that hasn't been demonstrated in the research to date as far as I'm aware. What has been demonstrated is that meditation practitioners, or even people just learning some basic skills, comparing before and after learning those skills, show a greater ability for functional neuroplasticity of the posterior cingulate. So the ability to tune it up and down more at will, or with intentionality. So that capacity to slow down that particular circuitry that is so central to the awake, abstract thinking state of the human animal seems to me to be a potential mechanism by which the brain may be preserved. In other words, turning off that incessant self-talk and abstract engagement that we tend to be engrossed in during our waking state may actually protect it from some of the long-term, cellular attack via these neurodegenerative processes that Dr. Chu, you're so aware of. And of course, we don't have clear evidence for that yet. You'd really need some longitudinal study to demonstrate that hypothesis as being false or not. But it is one intriguing possibility based on the literature that we do know to date, which does include some clinical studies, especially for mild cognitive impairment, showing some enhanced cognitive function related to mindfulness practice.
Yeah, that's a great point. We actually tried to get a rumination scale into our PCC fMRI study, but I actually had to drive to Albuquerque, and I only had a week to run that study because I was living in Tucson. I couldn't get the IRB updated, but just in post-experiment questioning, we asked the subjects, what was your internal talk space, or your sort of internal mental space like? And every subject except one reported an extreme quieting of inner talk, specifically the narrative voice that's typically telling you, mean things about yourself. That voice went down, which to them was very significant because they're in the scanner for 45 minutes. We were actually doing MRS. We were doing spectroscopy to look for negative effects from ultrasound to make sure nothing bad was happening, and we were doing ASL. So we had this whole long fMRI protocol. And at the baseline, all the subjects said, oh, that really sucked. 45 minutes, I couldn't move, and the thing is shaking. After the ultrasound perturbation on the PCC, they all reported like, oh my gosh, that went by so fast. There was no talking. I was really sort of attentive to the external world. So it really did reduce what you're talking about, Raul, in that sense of that sort of narrative type of space. To the question about athymorrhea, that's a really interesting question. And often when people learn about equanimity, they often think we're talking about apathy. It kind of sounds like apathy. If you're equanimous, you're just, you're cool, dude. You're cool with whatever is happening. But actually, equanimity is sort of the opposite of apathy, which is very interesting to think about the basal ganglia as the center. We know it has a lot to do with apathy because it shows up in Parkinson's and Huntington's disease and all of that. But it's also, with the right functioning of the basal ganglia, may actually subserve equanimity, which is basically being able to totally focus your attention, but not get so sort of wrapped up in what's going on. Whereas apathy is just sort of like you don't care, you're not motivated or whatever. Equanimity takes a high level of motivation for a meditator because you're often sort of focusing into painful emotions or painful. If I'm sitting for an hour in a meditation chair, it really hurts, and I'm sort of using equanimity to deal with that pain. And it seems like the basal ganglia may be one area that subserves that as well. And so, of course, we're very focused on the disease model and apathy, but if the meditators and the mindfulness teachers are right that equanimity is the flip side of apathy, it makes sense that it might be in the same brain area.
Alex, just in case there are a last question or two, can you give the clear instructions to everybody about how they raise their hand so we can see to call on them?
Yes, so you can just go to your own, if you like, you can go to your own name, and then clicking on the three dots, you should have something that says raise hand. And if not, you can open up the participants window, and on the participants window at the bottom, on the left hand side, actually, you'll have something that says raise hand. So either way, you can raise your hand there. And other than that, I'm looking out for you, so I can see you if you raise your hand, if your video is on. If it's not, then you just have to go to the participants window or the three dots. So.
Great, thank you. Maybe we'll just give a moment here to see if anybody else does have a question.
Sure. Muted, and I already have a little bit of the spotlight. I just wanted to say, Jay, thank you so much. So I am a patient of Ehlers-Danlos syndrome, which causes excruciating pain and dislocations and subluxations constantly. I'm also a long-term meditation practitioner and mindfulness teacher. And so this is so interesting because a lot of the Ehlers-Danlos syndrome, there is no cure for this. And so there's only opiates to kind of manage pain, and just to know that there's hope, at least for patients that really don't practice or cannot practice for other reasons, it's really it's just so hopeful. And I just wanted to thank you so much for doing this research. So
my pleasure.
Yeah, thank you. Super
lucky to get to collaborate with Shinzen on all of this, and I've been a practitioner for 10 years, and it's really sort of changed my life. As a vision researcher, I never thought I'd be doing mindfulness research. I thought I'd be a vision researcher till I die, but to be able to actually do this work and use the technology to try to enhance it. You know, I feel very lucky to do this every day. And, you know, especially if we can get patients over that initial hump in clinic, because if you have chronic pain, it's really hard to sit and focus on that pain. I know I've had, you know, we've had patients who tried this, and Shinzen's written a whole book about this. But if you can get people over that hump and give them some of that insight, that once they get what equanimity means, and that they can experience the pain but not have so much of that sort of stuff that happens afterwards, you know, that's really the key for us. And so we really hope that the intervention is not a long-term intervention, that we can bring people in maybe for 2 weeks, they get a couple ultrasound boosts to the right areas, and then they go home with an app or something like that where they can continue the practice. You know, and that's really the dream for us. And we think, you know, if that can just get the people involved enough and enough of a taste of the experience, you know, they'll do it on their own. But for patients, it's very difficult, as you know.
Yeah, definitely. And I think that's what I read the most on the forums. I mean, it hurts to just even sit for 20 minutes. So to really have them sit for extended, you know, hours or extended periods of time for mindfulness to actually kick in, and they can see some progress, can take quite a while. So, so yeah, so I wish you the best of luck, and I think it's wonderful research. Thank you.
Thank you.
Well, great. Maybe I'll just say some wrap-up words on behalf of the Center for Mindfulness Science, and then turn it over for you, Dr. Shilian, if you have any final words. Thank you very much to you, Dr. Chu and Dr. Shilian, for co-hosting this talk. I hope it was of benefit for the department. And the Center for Mindfulness Science here at USC will continue to host some of these virtual talks over the coming months until we are able to go back to business as usual. We hope to continue to coordinate our collaborations with others at Keck School of Medicine so as to become a little more integrated into clinical care and translational neuroscience and research. And also, as I mentioned at the outset, Dr. Sanguinetti will join us for one more talk in a couple of weeks. The date has yet to be nailed down for sure, but it's going to be relatively soon. And I'll put the word out through our listserv, which you can sign up for on our website, mindfulscience.usc.edu. And that will be a little bit more theoretical exposition on mindfulness and neuroimaging and neurostimulation, which is actually somewhat of a contentious field in the field of mindfulness research and especially mindfulness practice. And a lot of interesting work to do there. So thanks again for everyone for tuning in. And Dr. Shilian, would you like to say any final remarks?
And I muted myself again. I just wanted to say thank you so much. I think the collaboration with Center for Mindfulness Science is great for, I think, different aspects of neurology, I think, would benefit from collaboration. Thank you so much, Dr. Sanguinetti, and we would love to, for your next talks, to get the neurologists involved, and hopefully I'm sure there'll be a lot of interest from our department to be involved and to participate and listen to more. Thank you so much. Thank you very much for co-hosting with us. And Dr. Chu had any final? Thank you, everybody. Thank you so much. I appreciate it. Look forward to hearing more of your talks. Thank you.
Thank you for the invitation. This has been great.
Thank you.
Many people.